From the 22 News Plus studio, this is 22 News in Focus with Patrick Berry.
Hello, everyone, and welcome to this edition of In Focus. I am your host, Patrick Berry. And although October is Cancer Awareness Month, every day should be cancer awareness for all of us because cancer is prevalent throughout our families and our friendships. It is everywhere. We all need to be more aware of cancer, which is why today, across the desk from me, I have Dr. Agnes McAuliffe. She is the medical oncologist over at the Sister Caritas Cancer Center at Mercy Medical Center. Dr. McAuliffe, thank you so very much for joining me. I appreciate your time.
Thank you so much for having me.
So you are a cancer doctor. It's what you do. Why did you get into that medical field? Did something like most of us, cancer hits close to home and it changed your career path?
Yeah, so good question. I sort of came into medicine initially. I really enjoyed healthcare and putting together all the pieces about science and helping people get better. And then as I was on my medical school journey, I realized that I really enjoyed both working with cancer patients and learning about cancer treatment. Not only that, but during the time that I've been in my training, the treatment of cancer has expanded significantly. And there's so many more treatment options that are available.
And it's better now than just in the short 10 years ago than when you first entered the field.
Absolutely. Even from June of last year to June of this year, 20 new cancer drugs approved by the FDA.
Wow.
Every month, new drugs are expanding their indications and formulations, allowing for patients to receive them more frequently or through injections rather than infusions. So it really is an exciting time.
And I mean, you're still young in your career. So but just the way you explained it, you've already seen great advancements in medicine in just the last few years. Is it speeding up? Like, were the advancements slow? And then all of a sudden, just medical technology has changed, that things have just sped up faster and faster for the better?
I think that's one way to think about it. I think through different clinical trials and research, we are finding more the drivers and the causes of certain cancers, and also how to target mutations in cancers, such as in lung cancer. We found, targetable genetic mutations that we can use to give personalized targeted therapies. And the similar thing goes for, immunotherapy as a whole new class of drug as a whole, which also has really revolutionized treatments.
Do you specialize in any one particular form of cancer, or are you looking at it as a whole?
I look at it as a whole. At Mercy, we all see all kinds of cancer types, and we work together through multidisciplinary teams. Working with surgeons, radiologists, pathologists to formulate the best plan of care for every single patient.
So here locally in Western Mass at Mercy, at the Sister Caritas Center, you're seeing every form of cancer come through the door and adjusting your treatment to that particular patient.
Exactly.
Are any two patients the same?
I would say no.
Okay.
Everybody, I think, is a little bit different. And it depends on, not only the stage that the patient was diagnosed, the type of cancer they have, family history even plays a role. And all of that really takes into account the best treatment for the patient at that moment in time.
So as an average citizen, how important is early detection? I mean, it sounds like a kind of a silly question, but it really is very important, isn't it?
It is. Early detection allows for better treatment outcomes, less aggressive treatments that we have to use. It increases the odds of survival. Screening is one of these things that, against the even global challenge of cancer, can really help us find cancers at an early stage, and in some cases even prevent cancers.
There are ways to prevent cancer? I thought cancer was sort of in your DNA and there were triggers that made it happen, but you're the doctor.
Sure. So, for example, for colon cancer,
Okay.
The recommended screening is something called a colonoscopy, where the doctor will go in and visualize inside the GI tract to see if they find any abnormalities. If they see something there, something called a polyp or a precancerous growth, it can actually be removed at that time during the colonoscopy.
So at what point should people be getting colonoscopies?
Good question. So that guideline actually recently has changed. It used to be age 50, and now it's gone down to age 45, in part to a rising incidence of colon cancer in patients at a younger age.
So is there a reason why? I mean, are you able, in your field, are you able to pinpoint why colon cancers, there are a greater number of colon cancer patients under age 50 than maybe 15 years ago?
Yeah. So right now they haven't pinpointed one reason, but there's been, estimations as to multiple factors that could be at play for this. And that includes, genetic factors, family history, patients with a history of predisposition genetically to developing colon cancer.
So if you have some form of cancer in your family, there's a greater likelihood that you might get it.
There can be. In addition to that, lifestyle factors, a diet that includes more processed foods, an increased rate of obesity. These things also are playing into account. And the last thing felt to play a role is the disruptions in the gut microbiome.
What do you mean by that?
Through various, in every colon, there's good bacteria and what we call bad bacteria.
Right.
And so it's felt that there can be some overgrowth of bacteria that can, in time, alter the environment that allows cancer to grow, whether it's through, being exposed to antibiotics at young age over time. Again, we don't know. These are all things that have been proposed over the last year or two, as we've noticed these cases really increasing.
But it takes the research to determine whether those assumptions are true or false.
Exactly. And a lot of it, is hard to pinpoint one thing because there are so many factors at play. And so, evaluating one patient with cancer and all the factors in their life can compound, so necessarily a factor doesn't equal causation.
Right.
Correlation doesn't equal causation.
We are up on our first commercial break. We're here with Dr. McAuliffe from the Sister Caritas Cancer Center at Mercy Medical Center. We'll be right back after this.
This is 22 News in Focus with Patrick Berry. This is 22 News in Focus with Patrick Berry.
Welcome back, everyone, to this edition of InFocus. I am your host, Patrick Berry. Across the desk from me is Dr. Agnes McAuliffe from the Sister Caritas Cancer Center at Mercy Medical Center. Thank you so very much for joining me, Doctor. I greatly appreciate your time. I want to circle back to the preventative measures because you said you indicated that several forms of cancer are caused or triggered by the way you live your life, the way you eat, lack of exercise, whatever it might be. Explain to me some of the preventative measures that any of us can take now, no matter your age, to reduce your risks.
Sure. So, one of the bigger ones will be avoiding tobacco use or smoking cigarettes. As we well know, that has been linked with lung cancer significantly. So avoiding tobacco products is the big one. Another one would be, healthy eating and exercising, maintaining a healthy weight. When we think about skin cancers.
Let me ask you quick. Let me interrupt you there. Smoking, I get.
Sure.
How does food trigger cancer?
Yeah, I wouldn't say it's food itself. It's more the nutrition can lead to obesity, and increased fat cells can lead to hormone disruptions, which can lead to certain kind of cancers that are putting you at a higher risk for certain cancers.
Okay, so by watching your diet, getting some exercise, you're just reducing your risk.
Correct.
Okay.
Correct.
All right. You started to lead into one thing that I've forgotten already.
In terms of skin cancer.
Skin cancer, thank you.
If we're thinking about skin cancers, avoiding UV radiation, sun exposure, using sunscreen, skin protective clothing, especially during noontime hours, that's another step.
Do you find skin cancer as a whole has been reduced just from an educational standpoint of, sun lotion? I got to be honest, when I was a kid, sun lotion wasn't an option.
Yeah.
It was burn, peel, repeat all summer long. And for this fair skinned guy, I didn't think twice about it until I was probably in my late 20s, my now wife is like, you don't wear sun lotion. And now our kids are, wear it. But fast forward, I've had multiple bouts of skin cancer. Luckily, nothing too dangerous. But do you find that skin cancer has been reduced just because the knowledge has grown?
I think that's definitely a good part of it, that people are more aware of the risks of, the radiation from sun rays leading to cancer. So they are, using sunscreen at younger ages, definitely. And, becoming aware of also what to look for on the skin if there's, concerning spots or lesions or growths, are, talking to their doctors about that as well.
But again, prevention also, aside from, the long sleeves and the sun lotion, regular dermatologist visits.
Exactly.
And they'll, what you might think is a mole or a freckle could be something worse that they can, like your colonoscopy, take care of early rather than having it develop into something. What are some of the other preventative measures for cancer? So we talked about watch where no smoking. Obviously, I think everybody understands that. Watch what you eat, skin protection. What are some of the other measures?
Sure. So I think one interesting part of prevention that we might not necessarily come to the forefront is the success story of actually the HPV vaccine.
HPV. It's on the tip of my tongue, but I don't recall it.
The human papillomavirus.
Okay. Does that only affect women?
Actually, no. The HPV virus can cause not only in women cervical cancer, vaginal cancer, but also in men and women head and neck cancer, as well as anal cancers.
Wow. So I know my daughters had the HPV vaccine when they were younger. I never got it. I don't know of any men who have had it.
And
should we?
That's correct. So it used to be just females. It was only approved at that point. But more recently, the indication for the vaccine has expanded actually to include both boys and girls, starting at age 9, going all the way up to age 21.
Okay.
After 21, up to age 45, it's a discussion with your doctor whether or not you could be a candidate for the vaccine.
Again, family history kind of your doctor might ask you to have it done.
Correct. And, HPV being tied to these other cancers, if you can receive the vaccine and prevent essentially 90% of cervical cancers by these HPV subtypes that are covered for, that's a remarkable preventive success story. The problem is the uptake generally is low. I think part of it is, people are not all educated about, who can receive the vaccine. And it's a discussion with the children's pediatrician, really, and as you get older with your doctor, if you're a candidate for that vaccine.
Now, do you find that cancer knowledge makes you, I guess, a better cancer patient and patient advocate?
I think so. I think it does.
So I guess conversations like this, or with your primary care, just the more you know, the better you off are in protecting yourself. And if you have a family member who's going through it, you can be a better patient advocate.
Exactly. I tell my patients that really knowledge is power, and, there's never a wrong question. So, being educated about these things, there's a lot more access to, credible reading materials now that you can know what questions to ask and think about where to go.
When you look at cancer as a whole, is curing cancer better today than it has been, or worse? And then if it's better, which I think is the answer, what are some of those cancers that are out there that are still mostly incurable?
Yeah. And, that's a good question. Cancer survival rates are really right now at an all-time high. If we look at, the major cancers across the board, something we call 5-year survival is approaching 70% for many of those cancer types. But as you mentioned, there are some other cancer types that the survival rate is not quite as high. And we hope that through research, we can get new targeted therapies over the next few years that can be approved in those types.
Now, for patients of Mercy, does Mercy have partner hospitals that you work with? So, and I'm just trying to think, if no one's really local here to Springfield, but they need to take advantage of it, do you have partner hospitals in the region that people can use?
Yeah, we often work with Dana-Farber. Patients can go there for clinical trials if needed. But apart from a trial, we offer, the majority of other cancer care, chemotherapy, immunotherapy, radiation right here locally
Wow. So
in
people don't
Springfield.
have to travel to
So
Boston,
people
New
don't have
York.
to
Right.
travel.
Right.
Exactly.
We are up on our next commercial break. We'll be right back after this.
This is 22 News in Focus with Patrick Berry. This is 22 News in Focus with Patrick Berry.
Welcome back, everyone, to this edition of In Focus. We're here in the 22 News Plus studios. I am your host, Patrick Berry. Across the desk from me today, from the Sister Caritas Cancer Center at Mercy Medical Center, is Dr. Agnes McAuliffe. She is a medical oncologist specializing in all forms of cancer. Dr. McAuliffe, thank you so very much for joining me. I appreciate it. I was reading some statistics. You talked earlier about colon cancer and your colonoscopy. It was usually age 50 and above. Make sure you're getting it. But that dropped down to 45. I've been hearing that there are greater instances of breast cancer in women in their 40s because, again, if I understand correctly, mammograms usually were when you turn 50 for a woman, you start your mammogram. But
Right.
now that's come down similar to the colon exams.
Yes. So recently, given that increased incidence, changing to younger ages, and the guidelines can vary by several professional societies, but in general, starting at age 40, now you can discuss with your primary care doctor or even your gynecologist as a woman the indication to get a yearly mammogram. And some women, so those with family history, those who may have a genetic mutation or that may have dense breast tissue, they might also talk to their doctor about additional screening tests such as MRI or ultrasound that might need to be done, or even screening starting earlier or more frequently based on those findings.
What if, maybe there's some folks watching this who might be adopted or estranged from a family. They don't know their family history. Are there tests that people can take to forewarn them, maybe?
Sure. So, we know that about 5 to 10% of cancer cases in general can be linked to a genetic cause.
That low.
That low. And if
Interesting.
we think about it, the indications for testing are in certain cancer types, patients with triple negative breast cancer, pancreatic cancer, all those patients should have genetic testing. Patients who have, known first degree multiple relatives with cancers also should consider testing. So the patient with an unknown family history without a personal cancer history may not qualify to get the genetic testing, but it is always, again, worth a conversation with your doctor or provider about the risks and benefits. And most of the time, these tests are done in conjunction with someone called a genetic counselor who can talk to you about your personal risk and what the results mean to you if they come back positive or negative.
Do you have a recommendation by age of how frequently we should be seeing our doctors? I'm 58 years old, so should I be seeing my doctor annually or semi-annually versus somebody who's 40, who's like every 5 years? Again,
Sure.
eliminating that family history.
Right.
Is there sort of a benchmark or yardstick?
Sure. So being outside the primary care world, from what I see most of the time, they like to check in annually, at least once a year. And if, you're being followed more closely for other medical purposes, you might see your doctor more frequently than that.
So it doesn't really matter your age. It's just, make sure you see your doctor.
Correct.
And I can tell you firsthand, finding a primary care doctor right now is very, very difficult.
Yes.
It's hard. But again, as I age, I get nervous because I want to have a good, solid primary.
Yep.
Because again, I don't have it in my family.
Mhm.
There are some heart issues in my family, but I just want to be checked out regularly.
Right.
But hopefully I never have to go visit you.
Hopefully not.
Right. But are the number of cancer patients increasing? Like, is your workload increasing?
Yes, the number of cancer cases is increasing. Part of that is due to the increase in population, is due to, patients living longer in general and cancer being known to be more frequent in older patients. But people are surviving longer just with all the treatments that we have. It's estimated that as of the beginning of this year, there was 18.6 million cancer survivors in the United States alone.
Wow.
from the American Cancer Society facts. So that's an amazing statistic, really.
One thing I had heard a doctor say years ago was everyone will get cancer depending on how long you live.
Mhm.
So and I think he was speaking more towards prostate cancer for men, but
Sure.
it was one of those things where you're bound to get it the
Mhm.
longer you live. Is
Mhm.
that accurate?
More for prostate, yes, like you said, as men age, that risk definitely increases, but it is becoming more prevalent.
But the good news is it's becoming more and more curable.
Right.
You mentioned earlier something about immunotherapy,
Mhm.
and before we go, I want you to talk more about that because I don't know anything about immunotherapy.
Sure. So, immunotherapy works very differently from chemotherapy. Chemotherapy goes after rapidly dividing cells, which are the cancer cells, but can also have side effect on other cells like, your hair loss,
Mhm.
or the bowels, GI tract, leading to nausea. Whereas the immunotherapy really targets and harnesses the power of the body's immune system. So, cancer and tumor cells are smart. They actually try to hide from the body's immune system, and so that they don't get attacked. And what the immunotherapy does is it kind of removes that blockade and allows the treatment to go after the cancer cells, so the immune system to go after the cancer cells and
So
kill them off.
your built-in immune system,
Mhm.
the immunotherapy aids your built-in immune system to attack the cancer cells.
Exactly. Yeah, it's quite remarkable.
Is it a drug?
It
It
is.
certainly sounds
It's
like
a
it.
drug. It's right now given mostly through infusional therapy.
Okay.
Now they're having new formulations that are given as subcutaneous injections, but right now it's infusional.
And I know treatment for every cancer treatment is different. Is
Mhm.
immunotherapy the same? Every immunotherapy is unique for each form of cancer?
Good question. And, initially, the specific immunotherapy drugs get approved for one cancer type. More recently, they are getting approved for something called cancer agnostic. So across the board, if certain markers are found in a cancer cell that they might respond well to immunotherapy, it can be utilized. Um, but it is different drugs are used in different settings. Even stage 2, 3, or 4 in different cancers can be used, before surgery, shrink tumors down, after surgery to prevent recurrence, in stage 4 to treat the cancer. So there's really very many ways we can use the immunotherapy now.
This is a difficult question. Is stage 4 a death sentence?
Good question. And, the way we think about stage 4 metastatic disease is very different now from even 10 years ago. With immunotherapy and the advent of these targeted therapies, um, has really improved how long patients can live on treatment for stage 4
Hmm.
cancers. We take, for example, melanoma. In, 2011, we would think that the average patient would have 6 months if they had a stage 4
Wow.
diagnosis. But recently, last year in New England Journal of Medicine, one of the trials about dual or 2 immunotherapy drugs used together in these stage 4 patients, 50% of the people were still doing well at 10 years, which
Really?
is really remarkable. So it's really changing how long and how well patients can go on with treatments.
So that belief that stage 4 is a death sentence really isn't the case anymore. There are treatment. I mean, not in all cases, but depending on what you have, there are treatments that can extend your life for a significant time.
That's correct. And there still are cancers, such as pancreatic cancer, glioblastoma, that in the stage 4 setting, the treatment options are a bit more limited,
Okay.
and the lifespan won't go quite as long.
Wow.
But yes, in other cancers like melanoma, lung cancer, the options are much better than they used to be.
Dr. Agnes McAuliffe, I can't thank you enough for joining me today. A fascinating conversation.
Yeah.
Like I said, hopefully I'm never one of your patients. Thank you for being here.
All right.
I
Thank you so
appreciate it.
much.
This is 22 News in Focus with Patrick Berry.